on and off with exacerbations and remissions, coming from discs in her lower back, and we're here to fix 2 of those discs today. She actually has 3 or 4 that are causing the pain. We're going to fix the worst 2. Are you ready? All right, I'm going to give you a little numbing medicine. You might feel a little stick and burn. That's normal. Just lay still. You're okay. Sorry about that. That's just medicine going in. You're doing great. All right. Just let me know if you're uncomfortable, okay? And I'll give you some more medicine. All right. So we're going to go after the L4-S1 disc first. That's the bottom disc in the spine. Shot. Now you can see from her MRI shot that she's got basically several discs that are damaged. Shot. And our goal here is to get into those discs and fix them. Shot. To do that, we're going to enter through what's called the neuroforamen, which is a hole that's located on the side of the spine. Shot. Shot. A little bit lower than I want to be. Shot. Shot. There's the facet. Shot. So I need to be a little bit more lateral. Still facet. Shot. 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 And L4-S1 is absolutely the hardest disc to get into. As a matter of fact, the endoscopic spine surgeons I know, shot, many of them won't even do L4-S1 because they won't do a transforaminal shot because it's just so hard to get to. Good. Shot. I'm pretty close. Getting closer. AP. Let's go AP. You can see the needle tip is there at the L4-S1. She has a little bit of scoliosis, which is a slight curvature of the spine, most likely degenerative. Well, you can see that facet joint is pretty arthritic too, right where the needle is. I've gotten around it. I'm heading for her disc. So far, so good. Are you comfy? I'm right on the herniation right now. Shot. This is the L4-S1. I think I'm a little lower than I want to be. I want to come up just a little bit. Let's see what we can do. Shot. Shot. I'm rubbing right on her facet joint. We were talking about that earlier. That's the disc. All right. You okay? Give me an AP. Let's check out the AP. So AP means anterior posterior. It's a different view with the X-ray machine. It's looking pretty good. She all right? Are you comfortable? Okay? You comfortable? We're going to make our incision. This will be a 1/4 inch incision. And through this incision, we're going to fix 2 discs, the L4-5 and the L5-S1. Can you line up that 4-5 a little bit better for me? Shot. Still, the end plate of 4 is a bit wonky. I think we're off on WAG just a little bit. Tiny bit, like 1 degree. That's better. It's still wonky, but it's definitely better. Shot. All right. Well, we talk about spines that are closer to the surface versus those that are deeper. She's definitely got a deeper spine. Shot. Give me an AP. You can just see from the trajectory of the needles that I have to aim down. It's looking good. Back to a lateral view. All right, so we've already accessed L5-S1. We're about to access L4-5. We're going to perform our discogram in just a few minutes. She doing all right? Shot? She okay?
Yep.
Are you comfy?
Doing okay? You doing all right?
Let's get her awake.
Can you open your eyes for me? Can you open your eyes?
Now, this patient has had lower back pain. Huh? No. No. Aggravation, yes. She's had back pain for a while. And her pain is primarily in her lower back, right at L5-S1. And L4-5. You okay?
Can you open your eyes for me? Can I ask you a few questions, all right? You okay?
She also has pain at L3-4. We're not fixing L3-4 today. How you feeling?
Comfortable? Are you comfortable? She said yes.
How many years have you had back pain? When did it first start?
When did your back pain first start? Do you remember?
How many years ago?
How many years ago? Since when?
We're collecting some
Say
information.
it a little louder.
How many years ago did did your back?
Soft spoken. Say it a little louder.
How many years ago did your back pain start?
She said 6 years.
6? I think it's longer than that, but we'll just put 6 years. 6 years. She had a flare-up of that back pain recently, a few months ago.
Yes, May.
So, are you comfy?
Okay? Yes? Yes, she's comfortable.
All right. How bad is that on a scale of 1 to 10? How bad is that on a scale of 1 to 10? How high does it go? 10?
10?
Is that where you typically get your back pain?
Yes.
All right, so that's 10 out of 10 at L4-5 concordant. That means that disc definitely causes her daily back pain that she gets. What's called concordant. Concordant means pain that you typically get. Whereas discordant means I never get that pain, never had it before. So that's concordant. You okay? Is that better?
Okay? Yeah.
All right, we found one of your bad discs. Shot. This one's tough. I cannot inject dye. Give me an AP. Uh-huh. That looks pretty good. Well, you can see the nerves where the dye at L4-5 has gone around the nerve roots. Yeah. There you go. On both sides. I'm not able to get much dye into L5-S1. Let's take a look at 5-1. You can put her to sleep. I'm not able to test L5-S1. All right. I want you to count from 1 to 100 out loud. Can you do that? When you wake up, we'll be done with your surgery. Count out loud. Nice and loud. I want to do L4-5 first. I want to get that needle out of the way so we can get a 5-1 really good, because I'm going to have to lean. All right. We're going to start with the L4-5 disc. Shot. You can see the guide wire there. I'm going to remove the needle. Shot. So far, everything's going very well for her. I was able to test one of the two discs with a discogram, and it was 10 out of 10 concordant pain, which is her typical pain. Shot. Now I'm going to bring this dilator down. Keep an eye on it on the x-ray. Shot. You see the herniated disc there right in front of it? Shot. Uh-huh. Very good. So now we're at the back of the disc herniation, and we're about to enter the disc herniation. We call this technique outside in because I'm starting on the outside and going in. Shot. Shot. All right. Yeah, that's your first disc we're fixing. Everything's going well. And we're using the num-num inside the discogram, right? Material?
Yes, sir.
You're okay. It's all good. Want me to wait? Yeah. She's doing awesome. So we're inside the L4-5 disc. We went right through the tear in the back of the disc where the herniation came out. And basically I've shoved some of the herniation back in. We're going to go fish it out.
Should be okay now.
Yeah, it's fine. Any questions from the audience?
No current questions, but we do have a comment from Sago on YouTube.
Sago, nice.
And they said, Dr. Duke, I am completing my MRI and I hope to hit you up soon, God willing. I'm a med student, and ever since my herniated cervical discs, my grades have been affected. My dad said he might be able to help with the expenses, and I also have insurance.
Not a problem, Sergo. We look forward to helping you. Yeah, you don't want to live your life in pain from a herniated disc. One thing I know about herniated disc pain is it never goes away. It gets better on its own sometimes when you take it easy. But then as soon as you get active again, the pain comes back. So unfortunately, the only way to really deal with a herniated disc that causes pain is to treat it this way with surgery. The Duke laser disc repair is the best surgery in the world. That's why we do this surgery. I do fusions as well. I've done artificial discs, but those surgeries are far more invasive and cause complications. This surgery has never had a complication from the surgery, so it's safe. When you're a patient and you're evaluating what's the best way to treat my problem, you really want to have the most effective treatment that's going to get rid of the symptoms permanently, and you want something that's safe, so you don't end up, with a complication from surgery that you have to live with the rest of your life. And unfortunately, spine surgery is one of those types of surgeries where if you get a complication from spine surgery, it could be a permanent hoarseness or permanent swallowing problems, and you'll never be the same. And nobody wants to have surgery where they wake up from surgery and they have a new problem they didn't have going in. So it's very important, in my opinion, that you provide patients with an opportunity to do a treatment that's actually going to work the best for them, but also is the safest option. And the complication rate is very low. We've never had a complication with the cervical Duke laser disc repair. You only need to be here 3 days. Anybody that's considering traveling to Duke Spine Institute for their Duke laser disc repair, it's a 3-day process. Monday, Tuesday, Wednesday, and Wednesday afternoon you can go back home. So Monday we spend the day in the clinic doing a history physical, going over paperwork. Tuesday is surgery usually, and Wednesday is a quick checkup before you head home. All right, what we see here in this disc, this is L4-5. You can see the laser fiber is the glass thing. By the way, that laser fiber is 0.5 millimeter wide. That's 0.5 millimeter wide. The blue is the herniated disc. Sorry. So far, everything is going well.
We have a question.
All right, I'll do my best to answer.
All right. This comes from Mary Ann on YouTube.
Hello, Mary.
And they ask, is it true that the extruded disc is reabsorbed by the body?
Hi, Mary. Is it true that the extruded disc is reabsorbed by the body? 100% not true. It doesn't happen. It's a lie. I hear this all the time. Typically, it comes from chiropractors who want patients to believe that if they do their chiropractic treatment for 3 months, that the disc will reabsorb into their body. It's not true. The herniation stays there. It will always be there. There's even MRI scans online I've seen where they try to convince patients that the herniation went back in on its own with therapy. It's not true. There's a lot of scams out there. Now, do symptoms get better from a herniated disc over time? Yes, they get better. Do they get worse? Yes, they get worse. So they get better and they get worse. And you get this cycle of worsening and bettering and worsening and bettering. But in the end, you learn that to stay better, you have to really avoid activities. No sports, no exercise, no lifting, no bending, no twisting. And basically, you're limiting your life. And you're cutting out all the things that are physical activities so that you don't set off your pain. Well, that's no way to live life. The best way to deal with it is to fix it with the Duke laser disc repair. Fix your herniated disc. Get rid of the pain. The Duke laser disc repair allows your disc to heal naturally. That's the key of the Duke laser disc repair. What I'm doing right now, see this blue stuff? Blue stuff is the herniation within the annular tear that keeps the disc from healing. This is the only surgery in the world that removes the herniation from the tear to allow the tear to heal. As long as the tear is not healed, you are going to keep getting herniations over and over again, and you're going to keep getting pain. The only way to get rid of the back pain from a herniated disc is to clean out this tear with the laser and let the tear heal itself. And that's what we're doing with this surgery. No other surgery does this. Laminectomy does not do it. Discectomy does not do it. Fusion does allow you to stop the movement at the painful disc, so that will help with the pain. But why do you want to do a fusion when you don't need it? Fusion is very invasive and has a high chance of complications. So going back to your question, Mary, Discs do not reabsorb. The extruded part does not reabsorb on its own. They do shrivel up a little bit. But the problem is not so much the extruded part, it's the tear. And until the tear is healed, it will continue to release more pieces of herniation throughout your lifetime. And the only way for it to heal is to do this surgery. It's called the Duke laser disc repair. The blue stuff here is the interposed herniation. It's basically the nucleus pulposus that's stuck within the annular tear. I've been treating herniated discs as a neurosurgeon now for 26 years. And I can tell you, there's so many myths, so much false information about treating them. And one of those false information is that they actually heal themselves. They don't. If they heal themselves, then people would be able to go back to normal activities and not have pain. Ever come back. So they definitely don't heal themselves.
We have another follow-up question from Mary Ann.
Sure.
Doctor, you said they do shrink?
They can shrink, yeah, because when you herniate the nuclear material, you have inflammation. Inflammation is swelling. And just like any swelling in your body, over time it goes down. So it's the swelling that goes down, and the piece of disc material that squeezes out, the extruded disc fragment, can actually shrink a little bit because it's also full of water. And over time it dries out. So it does shrivel up, but it never goes away on its own. Another thing to consider, as long as you have an extruded fragment, you're going to always have the disc degenerating and breaking down into smaller, it gets smaller and smaller. Look at that piece of herniation right there, the blue thing. See how it was just coming out of the annular tear? This is the debridement we talk about with the Duke laser disc repair. We're debriding the tear, getting rid of the scar tissue, calcium, and herniations. This is going to allow her disc to heal naturally. Great questions, by the way, so far from our audience.
We have another question.
Uh-huh.
This comes from Tennessee Mountain Girl on YouTube.
All right.
And they ask, would you please explain what a transitional lumbosacral junction is, please?
Transitional lumbosacral junction just means that there's some abnormality of the facet joints or the disc itself. And a lot of times it's a description by the radiologist describing an abnormal disc or, like I said, facet joints. Typically at the lumbosacral junction there's a nice big disc that's there, but in some people they have a small disc and they have small facets and they don't have really normal movement there as a result because the discs and the facets are not normal. So they have less movement than normal. They call it a transitional junction. Transitional because you're transitioning into the sacrum, which is a fixed bone. There's no movement in the sacrum. The sacrum is a solid piece of bone. And the discs of the sacrum, there is no disc, so there's no movement within the sacrum. It's a solid piece of bone that doesn't move. So a transitional lumbosacral junction means you're transitioning into a sacral type configuration, but in the lumbosacral junction. Of course, you can mean anything, but that's the standard meaning. It's nothing you need to do about that, by the way. It doesn't cause any symptoms. All right, we're just about done here at L4-5 on the right side. I'm cleaning all the herniation out, cleaning the annular tear. So far, so good. It's going very nicely for her. I could tell this has been here for many years. And she was really excited to have this procedure done. See a little bit of fat right there. It's normal to see fat around the foramen. The foramen is where the nerve root is. And remember, the nerve root uses a lot of energy, so it needs a good energy source, and fat is a great energy source. It's the best energy source we have. Of course, the brain does not use fat, so it wouldn't work in the brain, but around the nerves it does work quite well. Just about done here. You can see again the epidural space, a little bit of blood vessels. This is the last of the herniation, right here. So far we've had some really good questions from our audience. That's why we live stream, is so we can take questions and answer. Just about done. And what you're seeing here is the transition from the back of the disc, which is annulus fibrosis, into the posterior ligament. By the way, that's her vertebral body right there to the right at 3 o'clock. That's bone. You see that? Right there, that pinkish color. That's the L4 vertebral body. And that's the back of the disc right there. Grab her. See if there's any herniation I can get out. Just about done here with this one. Pretty much got most all of it out. There's really not much coming out at all. Feels pretty good to me. A lot of what surgeons do is tactile, meaning touch, and I'm not really feeling anything down there. Just a few little pieces. But I feel like we're 95% done here. A little piece there that wants to come out. Very happy with that result. Grab her. I think we've gotten everything out that we need to get out. So just so you understand, what we're looking at is the back of the disc here at L4-5. There was a tear, and the blue stuff came out through the tear, and I've removed the part that was causing pain. And now this area will heal, and it'll seal itself off. And that's what we want. We're done. So that's L4-5. Next, we're going to go down to the L5-S1, but before I do that, I want to put a little antiseptic called betadine. We've never had an infection with the Duke laser disc repair. It's the only spine surgery in the world that's never had an infection. All other spine surgeries have infections, some more than others.
We have another question.
Sure.
This comes from Food is Life and Love on YouTube.
Excellent.
And they ask, can
You're okay.
Can you do spinal cord decompression with the laser procedure, or is it too risky?
Can we do spinal cord decompression with the laser procedure? Absolutely. We do it all the time. It just depends on how bad the compression is. Since there is no spinal cord in the lower back, you must be referring to the neck or the thoracic. And the answer is yes. We can do spinal cord decompression in the cervical spine, which is the neck, or the thoracic spine. Either one. We've done it many times. Many of our patients that have cervical Duke laser disc repair have spinal cord compression. It's not a problem. As a matter of fact, most spine surgeons are afraid to do spinal cord decompression. So there's two types of spine surgeons. Well, there's three types of spine surgeons. There's neurosurgeons, there's orthopedic surgeons, and then there's non-surgeons who are trying to be spine surgeons, illegally, in my opinion. So neurosurgeons are trained to decompress the spinal cord. Orthopedic surgeons are not. And if you have an orthopedic surgeon doing your spine surgery, they're not going to decompress your spinal cord because they're afraid to paralyze the patient, and they probably will. So they stay away from cord decompression. That doesn't mean they won't operate on you. They'll still operate on you. They'll just tell you they're doing a decompression, but they're not. Does that make sense? There's a lot of unfortunate lying and cheating and nonsense that goes on in spine surgery. So orthopedic surgeons are not trained to decompress the spinal cord, but they'll tell you they're going to do that, but they don't actually do it. But they still get their fusion and they still get their money. Okay? Then you have neurosurgeons who are trained to decompress the spinal cord, most of us, but some of us are not well trained at all. And some neurosurgeons, about 50%, don't know how to do a decompression of the spinal cord, even though they're supposed to. They just never learned it properly. So they're not going to do a decompression either. And then, of course, you have these crazy doctors like some anesthesiologists or pain management doctors that are trying to do spine surgery, and they shouldn't be doing spine surgery, and they're definitely not going to decompress your spinal cord. So what I'm getting at is, of all the spine surgeons available to do decompression of the spinal cord, only a small percentage of them actually can do a decompression and do a decompression. The other ones will tell you they're going to do a decompression but don't actually do it. I don't know if that makes sense. Shot? That's it right there? Alrighty. So now we're heading for L4-S1, the bottom disc. And this is a tough one. How is she? She ready? Shot? Alright, so I'm going to have to get down to the disc, shot, and then I'm really going to have to aim medially with the tip just to get where I need to be. Shot. Alright, put a little pressure here. Sharp. Beautiful. So I'm right at the back of the disc, and as I said, I'm going to pull lateral and aim the tip medial. Alright, and the reason I'm doing that is I want to get more medial at L4-S1. Shot. Shot. All right. Very good. So far, so good. She's doing fantastic. She's sleeping. We've already finished one disc. We're getting ready to do disc number 2. As I said earlier, because her spine is so anterior, and what that means is her spine is so far forward, I've had to, you want to see? Take a look. Shot. Her spine is so far forward that it really changes the angle. Shot. That looks good, right? Yeah. So it forces my tube to go to the side where I don't want to go. I want to go towards the middle. And so once I got down there with the dilator, I basically, I'll show you guys what I did. If this is the side of the disc, I was like right here, okay, because the facet joint was pushing me laterally. I got past the facet, I'm sitting right there, but to get more medial, I had to drop this sideways to the right and aim more medially, which is what I tried to do. And we were able to do that. That way we can attack the herniation and the tear properly. But that's an advanced technique, very hard to do. Like I said, of the endoscopic surgeons in the world, they don't do L4-S1 transforaminal like I do, because they're not able to technically do it. They don't have the skill set. It's very hard to do. I've been doing it now for 16 years. And it's just, that's why you want to be careful who you choose as your surgeon. Not all surgeons are equal. That's 100%. We're definitely in the disc. All right. So we got, hello? It's weird. I'm good. All right, so we're going to fix this disc and then we'll be done with her. And our last patient is a plasma rhizotomy for facet joint pain. We have not broadcasted those yet. We're not going to. Not this one. We will this month start broadcasting them. Basically, there are two causes of back pain: the disc and the facet joint. Sure, there are a few other minor causes like fractures, tumors, infections, SI, piriformis, but the two biggest causes of chronic back pain are facets and disc. The Duke laser disc repair is what you're watching right now. This is the best treatment in the world for herniated disc, to get rid of the back pain and leg symptoms. To fix facet pain, the best treatment is the Duke plasma rhizotomy. And we've not broadcasted one of those surgeries yet. We will soon, but not yet. All right, any questions?
No current questions, but we do have a comment from Food is Life and Love from the question they asked before. They said, makes all the sense in the world. Thank you kindly for your wisdom.
Well, thank you. Sometimes I wonder if my ideas are getting across properly, but I try to say them in different ways so that people can understand it, make sense of it. Now, what I could tell you about this disc here at 5-1, look at all the scar tissue. There's so much scar tissue. This is an old injury. Look at that. That's an entire wall of scar tissue from inflammation, from the herniation in the annular tear. This poor woman has been suffering for years with back pain. She was part of the VA system, kept going to the VA hospital. Of course, the VA doesn't know how to do this advanced surgery, and all they do is shots and laminectomy and surgeries that don't work. We've all heard stories about surgeries that don't work. Nobody wants a surgery that doesn't work. Unfortunately, there's lots of surgeries that don't work that are being done. Yep, I've got about 5 minutes left. This is all scar tissue right here. You can see the herniation is the blue, and the scar tissue is forming around the herniation because the herniation creates inflammation, and inflammation creates scar tissue. So over years and years of inflammation going on in your back, inside the disc, that's what creates all the scar tissue. I was talking to Dr. Osman, Jim Osman, who's the professor at UCLA neurosurgery. She's also the former editor-in-chief, Surgical Neurology International, where we published a few of our Duke laser disc repair papers. And Dr. Osman is not a spine surgeon, but he's a brain surgeon like me, but his focus is on brains, surgery, and brain problems. Anyway, we were talking about the inflammatory basis of this condition, and he was quite shocked. And he said, you know what? It's coming out that almost all diseases are inflammatory base. Look at this pink tissue right here. That's full of little nerves that are pain-sensitive nerves. We want to get rid of that because that's where her pain's coming from. Little nerve pain fibers. So Luis, our last is going to be a plasma one side.
Yes, sir.
344551, I heard.
Yes.
All right. Any questions, Henry?
No current questions.
All right, let's run our video showing the audience how does a herniated disc actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, we're just wrapping up the second disc that we're fixing, the L4-S1, and I'll be done in 30 seconds. So if you have questions for me, feel free to type them up. I'll be happy to answer them for you. Now that I've cleaned out the blue stuff, this tear will heal itself. It's tried to heal for years. It's been unsuccessful. But now that I've taken out the herniation that was blocking it from healing, it is going to heal. And it's going to heal pain-free. That's what I expect. Just about done. 10 seconds. 5. We're done. Good job, everyone. All right, we're going to put a little betadine, antiseptic. Any questions you have, type them up for me and I'll be happy to answer them for you. You're all right, just lay still.
We're doing right. Doing all right.
Just irrigating out the betadine.
We're done.
Lay still, you're doing great. You're all right. All right, let me show you the whole surgery was done through a 1/4-inch incision. You're okay. You guys see this? Everything is done through this tiny little tube. I'm going to show you the incision in just a second. You're all done. You did great. Everything went very well. So the 2 discs that we fixed, the pain will be gone that they were causing for years and years. That chronic back pain she's had from those 2 discs, that pain will be gone. She still has a disc or 2 that needs to be treated, which we'll talk about in the future. But this should give her good relief. Go ahead and type up your questions for me, and I'll be happy to answer them. Everything was done through this tiny little cut. You guys see that, Henry?
Yes, we do.
1/4 inch. Thanks, Luis. Thanks, everybody. Go ahead and type up your questions, and I'll come answer them for you. Henry, why don't you run the video on how the Duke laser disc repair works?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Duke Laser Disc Repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Duke Laser Disc Repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke Laser Disc Repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke Laser Disc Repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke Laser Disc Repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke Laser Disc Repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke Laser Disc Repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke Laser Disc Repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Duke Laser Disc Repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-Strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I'm Dr. Duke Mason. We have just finished a Duke laser disc repair for a patient with herniated discs in her lower back at L5-S1 and L4-5. These two discs, the bottom two. I was able to get in And you can see how hard it is to get into the L5-S1. We were talking about that. It's the hardest to get into because there's not much of a window, and you've got to put that needle just perfect. The other discs are easier to get to, L4-5, L3-4, L2-3. But the L5-S1 is notoriously the hardest disc to access transforaminal. What does transforaminal mean? Well, there's different ways to get to a disc. You can go anterior, which is through the front, through your belly. You can go anterior retroperitoneal, which is behind the layer, the membrane here on the wall. You can go lateral, which is from the side. You can go transforaminal, which is through the hole that's already there. And you can go translaminar, meaning across the lamina. Translaminar procedures are the most common, most popular, but they're bad for you. Why? Because the surgeon is going to remove the bones called the lamina and the ligaments holding them together. It weakens your spine. So there's been efforts lately to find ways to get to the disc that don't involve damaging the spine. And the best way to do that is what we do with the Duke laser disc repair. There are other ways, but they're not as good, and they have complications like anterior transabdominal or retroperitoneal. The worst, of course, being the laminectomies and the discectomies, which take out the lamina and facet joint. So you've watched the most advanced spine surgery in the world, the Duke laser disc repair, done with a laser. You can see the laser in there doing its job, removing unwanted tissues that shouldn't be where they are, namely the herniation, and also cleaning up the tear in the annulus fibrosus. Everything went very well in the surgery for this patient. She does have other discs that need to be fixed. We haven't fixed them, and we didn't fix them today. She chose not to have them fixed, and that's her choice. I don't force people to do anything they don't want to do. But I think with the 2 discs that we fixed today, she's going to get some really good relief, and I think she's going to be very happy. I think the disc that we didn't treat, the L3-4, is still causing problems for her, but we'll see. She'll probably come back at some point and get that one fixed as well. All right. Otherwise, surgery was very successful. I'll take any questions you guys have.
No current questions.
No questions? Wow.
No.
All right. Thank you.
We all know everything.
Yep. And we'll be back on Thursday, I think.
I think so.
No surgeries Thursday?
Till next Tuesday, yeah.
Next Tuesday then. All right. Enjoy your day. Thank you.